Welcome to our video on pharyngitis and tonsillitis. Let's get started. We'll begin this lecture with a discussion of pharyngitis, as well as several of its high-yield complications, namely Lemierre syndrome, scarlet fever, acute rheumatic fever, and poststreptococcal glomerulonephritis. We'll then move on to a discussion of tonsillitis, peritonsillar abscess, and retropharyngeal abscess, along with its most notable complication of acute necrotizing mediastinitis. Let's begin with a general definition, etiology, clinical features, diagnosis, and management of pharyngitis. Simply put, pharyngitis is defined as inflammation of the pharynx. The pharynx is a hollow tube inside the neck that starts posterior to the nose and ends superior to the trachea and the esophagus. It's divided into three components: the nasopharynx, the oropharynx, and the laryngopharynx. Inflammation in any part of the pharynx would qualify for a diagnosis of pharyngitis. The most common etiology of pharyngitis is a viral infection, such as infection with rhinovirus or adenovirus. In fact, viral infections make up about 90% of cases of pharyngitis in adults. The next most common cause of pharyngitis is a bacterial infection, most commonly with group A Streptococcus, also known as Streptococcus pyogenes. Lastly, pharyngitis can be caused by other more rare etiologies, such as gastroesophageal reflux disease, or GERD. For the purposes of the USMLE Step 2, it's helpful to think of the clinical features of pharyngitis as either more suggestive of viral pharyngitis or more suggestive of streptococcal pharyngitis. This table summarizes the most common symptoms of pharyngitis and aims to help students distinguish viral pharyngitis from streptococcal pharyngitis. Both types of pharyngitis usually manifest as a sore throat and pharyngeal edema. Patients with viral pharyngitis are more likely to exhibit cough, nasal congestion, or rhinorrhea, coryza, conjunctivitis, hoarseness, and a viral exanthem. Patients with streptococcal pharyngitis, on the other hand, are more likely to exhibit fever, tonsillar exudates, painful anterior cervical lymphadenopathy, pharyngeal edema, sudden onset of a sore throat, and a rash suggestive of scarlet fever. As a side note, scarlet fever is a potential complication of streptococcal pharyngitis that can lead to a characteristic sandpaper-like rash, which we'll examine in greater detail later in this presentation. Once again, it's important to point out that there is a significant overlap between the symptoms of viral pharyngitis and streptococcal pharyngitis. Here's an image depicting a typical look of pharyngitis. Note the significant erythema, edema, and petechiae in this patient's oropharynx. And here's an image depicting the appearance of tonsillar exudate. As mentioned in the table on a preceding slide, this finding would be more suggestive of streptococcal pharyngitis rather than viral pharyngitis. All right, let's try a question. A 16-year-old female presents to the urgent care with a sudden onset of fever, sore throat, and extreme fatigue. Physical examination reveals tonsillar erythema and exudates, posterior cervical lymphadenopathy, and splenomegaly. What is the most likely diagnosis? All right, pause the video and take a moment to consider this question. When a teenager presents with a fever, sore throat, and extreme fatigue in the setting of tonsillar exudate, posterior cervical lymphadenopathy, and splenomegaly, the clinician should strongly consider a diagnosis of infectious mononucleosis. It's a common cause of pharyngitis among teenagers that's caused by the Epstein-Barr virus. Though streptococcal pharyngitis may have been a tempting diagnosis, it's usually characterized by anterior cervical lymphadenopathy, not posterior cervical lymphadenopathy. Furthermore, findings of splenomegaly further supports the diagnosis of infectious mononucleosis rather than strep pharyngitis. To learn more about infectious mononucleosis, please refer to our lecture titled Miscellaneous Infections from our infectious disease section of our medicine lectures. Though pharyngitis is largely a self-limited disorder, there are several complications that may occur in a small group of patients, all explained by the spread of infection into surrounding tissues. Notable examples include sinusitis, mastoiditis, otitis media, cervical lymphadenitis, retropharyngeal abscess, peritonsillar abscess, and Lemierre syndrome. Is a life-threatening infection that is most commonly caused by Fusobacterium necrophorum, a gram-negative anaerobe that's part of the normal oral flora. It's often preceded by pharyngitis, tonsillitis, mastoiditis, or dental work, and it usually affects young people. As such, this diagnosis should be considered if patients with a mild oropharyngeal infection begin to exhibit worsening fevers, rigors, or neck swelling and pain. Once the infection begins to spread, it may reach deep enough to involve the internal jugular vein, potentially leading to septic thrombophlebitis and septic thromboemboli. Septic thrombophlebitis is a term that describes a thrombus or a clot within a blood vessel in the setting of an associated infection. Similarly, septic thromboembolism is a term that describes the embolization of an endovascular thrombus in the setting of an associated infection. Depending on the extent of the clot and its embolization, patients may quickly decompensate and even expire, which is why it's so important to recognize Lemierre syndrome early and give the appropriate treatment. The diagnosis of Lemierre syndrome is made with a culture of blood or pus, and the treatment begins with supportive therapy, such as airway management and IV fluids. Patients should be promptly given IV antibiotics to target Fusobacterium necrophorum and oral streptococci, for example, with piperacillin tazobactam. Lastly, if patients do not respond to IV antibiotics, surgical intervention, for instance, vein excision, might be warranted. Notably, the role of anticoagulation remains uncertain in the treatment of Lemierre syndrome. Hence, always choose IV antibiotics over anticoagulation for management. Now that we've covered the general complications of pharyngitis, let's move on to discuss complications of streptococcal pharyngitis specifically. These include acute rheumatic fever, scarlet fever, and poststreptococcal glomerulonephritis. Acute rheumatic fever is a constellation of signs and symptoms that may manifest in patients with untreated strep pharyngitis within about 2 to 4 weeks of the onset of pharyngitis. Its clinical features are categorized under the diagnostic Jones criteria, which are divided into major criteria and minor criteria. Here is a table summarizing and categorizing the Jones criteria for acute rheumatic fever. The major criteria include joint involvement, such as arthritis or polyarthralgias, as well as carditis, subcutaneous nodules, erythema marginatum, and Sydenham chorea. The minor criteria include fever, monoarthralgias, prolonged PR interval, and elevated inflammatory markers. Generally speaking, the major criteria are all one needs to remember to recognize acute rheumatic fever on a test. These criteria can be remembered with the Jones mnemonic that spells out the first letters of each of the major criteria of acute rheumatic fever. In addition to knowing these criteria, it's important to recognize them on exams. So let's examine erythema marginatum and Sydenham chorea in greater detail. Here's an image depicting erythema marginatum, which is an annular erythematous rash with sharp raised borders and central clearing, as can be seen here and here. The name marginatum should help you remember the well-defined margins and raised borders of this rash. All right, let's try another question. What is the difference between erythema marginatum, erythema migrans, and erythema nodosum? Students often confuse the names of these 3 distinct rashes, so let's take a moment to distinguish them. Here are all 3 of the rashes side by side to facilitate comparison. As mentioned on the previous slide, erythema marginatum is an erythematous rash associated with rheumatic fever, and it's characterized by sharp margins, raised borders, and central clearing. Erythema migrans is the bullseye rash associated with Lyme disease, which we can see here. Notice that it's a flat erythematous lesion with a central clearing that makes it appear like a target. Finally, erythema nodosum is a rash characterized by painful erythematous nodules on the shins, and it's typically associated with autoimmune diseases, such as ulcerative colitis or sarcoidosis. Sydenham chorea is another complication of acute rheumatic fever to be aware of, particularly in children. It's an autoimmune reaction against the basal ganglia that occurs due to molecular mimicry. In essence, the antibodies produced against group A strep cross-react with the neuronal antigens in the basal ganglia in a process known as molecular mimicry. The clinical features of Sydenham chorea include rapid involuntary brief muscle movements, which is the definition of chorea. Notably, these movements tend to be worse with action. Other clinical features include hypotonia and psychiatric manifestations, like emotional lability and anxiety. A common example of emotional lability would be inappropriate or sudden laughter. The treatment of this condition is with symptomatic control, for instance, using antidopaminergic drugs. Of course, clinicians should also treat the underlying rheumatic fever that caused this condition in the first place. The prognosis of Sydenham chorea is good, with most patients achieving remission. All right, let's try another question. In a patient with newly diagnosed Sydenham chorea and confirmed group A streptococcal pharyngitis, which additional diagnostic step is warranted as part of the standard of care? All right, all patients diagnosed with Sydenham chorea must undergo a thorough cardiac evaluation with either an ECG or an echocardiogram. This is because Sydenham chorea may be the first manifestation of acute rheumatic fever, which can also lead to cardiac pathologies. The diagnosis of acute rheumatic fever is a two-step process. Patients must first have a confirmed diagnosis of group A streptococcal infection, and they must exhibit at least 2 major criteria or 1 major criteria and 2 minor Jones criteria. Treatment for acute rheumatic fever is with either penicillin or amoxicillin. Notable complications include valvular disease, particularly mitral valve regurgitation in the acute period, and mitral valve stenosis in the chronic period. Let's now discuss the next notable complication of strep pharyngitis, scarlet fever, and poststreptococcal glomerulonephritis. Scarlet fever is caused by erythrogenic exotoxins of group A streptococci. The clinical features of scarlet fever include features of streptococcal pharyngitis, such as fever and tonsillar exudate, an erythematous sandpaper-like rash, which we'll show in greater detail on the next slide, and findings of strawberry red tongue and circummoral pallor on physical examination. Since scarlet fever is a complication of strep pharyngitis, the treatment is to treat the underlying group A streptococcal infection. Here is an image depicting the typical sandpaper-like rash associated with scarlet fever. It tends to be most pronounced in the skin folds and tends to desquamate, resulting in peeling of the skin, most often on the hands and feet. Also note the characteristic reddening of the cheeks and the paleness of the skin around the mouth, which is what clinicians call circummoral pallor. Post-streptococcal glomerulonephritis is a nephritic syndrome that occurs due to immune complex deposition in the kidneys between the glomerular basement membrane and the mesangium. It typically manifests several weeks after group A strep infection of the skin or pharynx. It occurs more commonly in children who usually present with nonspecific symptoms, such as a headache or malaise. It may also present with hematuria, which is often described as cola-colored urine in the question stems, and finally, periorbital edema. Here are 2 H&E stains showing a normal glomerulus on the left and a glomerulus from a patient with post-streptococcal glomerulonephritis on the right. Note the thickened basement membrane and the inflamed hypercellular glomerulus on the right when compared to the normal glomerulus on the left. Labs that would be consistent with the diagnosis of post-streptococcal glomerulonephritis include proteinuria, hematuria, red blood cell casts, elevated serum creatinine, and low serum C3. The treatment for this condition is supportive, and it has a good prognosis with most patients recovering within a span of a few weeks. Now that we've discussed the definition, etiology, and the clinical presentation of pharyngitis and its complications, let's move on to the diagnosis and management. Is to distinguish viral pharyngitis from streptococcal pharyngitis. Several tests are available to assess for a presence of a streptococcal infection. First is the rapid streptococcal antigen test. Its main advantage is that it can yield results in about 15 minutes. Its main disadvantage is that it's less sensitive and specific than a throat culture, which is considered the gold standard. Unfortunately, a throat culture can take up to 24 to 48 hours to give results, which is why clinicians usually begin the diagnostic process with a rapid strep test. Other available tests for strep include anti-streptolysin O titers and anti-DNase B titers, both of which will be elevated in patients with a group A strep infection. That being said, most clinicians and exam questions rely solely on the rapid streptococcal antigen test and/or a throat culture to diagnose streptococcal pharyngitis. The challenge is in knowing the correct indication and sequence of ordering these tests. And to make things harder, the diagnostic steps differ for adults and children. Let's first walk through the diagnostic steps for pharyngitis in adults, which are guided by the clinical Centaur criteria. There are 4 criteria, each attributed a single point on the Centaur scale. These criteria include fever by history, tonsillar exudate, absence of cough, and painful anterior cervical lymphadenopathy. If a patient scores 0 to 1 points, strep pharyngitis is unlikely, and no testing or treatment is warranted. If patients score 2 to 3 points, clinicians should perform a rapid strep test to assess for the presence of the infection and treat the infection with antibiotics if the test comes back positive. Lastly, if patients score 4 points, clinicians may either offer empiric treatment with antibiotics or perform a rapid strep antigen test to first confirm the diagnosis. Note that throat cultures are generally not performed in adults. This is because the incidence of strep pharyngitis in adults is pretty low, which is why throat cultures are generally reserved for adults who carry a high risk of complications, such as those with a history of rheumatic fever. All right, let's try another question. A 31-year-old female presents to the clinic with a sore throat and fever. She denies cough. Physical examination is notable only for tonsillar erythema without exudate. What is the next best step in management? All right, this patient has 2 out of 4 Centaur criteria based on her fever by history and an absence of cough. Hence, the next best step in management would be to order a rapid strep test. If she tests positive, she should be treated with antibiotics. If she tests negative, a clinician should assume viral pharyngitis and treat conservatively. Though some study resources may suggest using the Centaur criteria or even a modified Centaur criteria in evaluation of pharyngitis in children, our recommendation would be to follow the steps in this algorithm. When a child presents with signs and symptoms of pharyngitis, such as a sore throat or pharyngeal erythema, clinicians should first assess the child for the presence of viral symptoms, such as cough, conjunctivitis, or rhinorrhea. If viral symptoms are present, clinicians should assume viral pharyngitis and should not perform any further testing. If viral symptoms are absent, on the other hand, the clinician should order a rapid strep antigen test to assess for potential strep pharyngitis. If the test comes back positive, it's likely strep pharyngitis. If the test comes back negative, however, clinicians should confirm the negative test with a throat culture. This is because strep throat is a lot more common in children than in adults, which warrants confirmation of negative rapid tests with a culture. A positive culture would be consistent with strep pharyngitis, whereas a negative culture would support the diagnosis of viral pharyngitis. It's important to point out that there is no need to confirm a positive rapid strep antigen test with a throat culture. Only a negative rapid strep test should be confirmed with the throat culture. All right, let's try another question. A 9-year-old girl is brought to the pediatrician with a sore throat and fever. She hasn't had any cough, rhinorrhea, or other respiratory symptoms. What is the next best step in management? All right, since this girl with a sore throat does not seem to have any viral symptoms, such as a cough or rhinorrhea, strep pharyngitis is likely. Hence, the next best step would be to order a rapid strep antigen test. On the previous slide, if the rapid test comes back positive, she should be diagnosed with strep pharyngitis and treated appropriately. If it comes back negative, on the other hand, the results should be confirmed with a throat culture. The management of pharyngitis depends entirely on its etiology. Cases of viral pharyngitis are managed with supportive treatment, for example with oral fluids or antipyretics. Most cases of viral pharyngitis are self-limited, and there is no place for antibiotics in their management. Cases of strep pharyngitis, on the other hand, are treated with oral penicillin as the first-line medication. Other drug options include amoxicillin, cephalosporins, and azithromycin. Now that we've covered all of the high-yield points regarding pharyngitis and its potential complications, let's move on to tonsillitis. Specifically, we'll discuss the definition, etiology, clinical features, diagnosis, and the management of tonsillitis. In simple terms, tonsillitis is characterized by inflammation of the tonsils. Similar to pharyngitis, tonsillitis can occur secondary to either a viral infection, for example with rhinovirus or adenovirus, or a bacterial infection, for example strep pneumoniae. As with pharyngitis, viruses cause tonsillitis a lot more frequently than bacteria do. The clinical features and complications of tonsillitis are also pretty similar to those of pharyngitis. Patients can present with a sore throat, fever, tonsillar erythema, exudates, odynophagia, and dysphagia. Physical examination findings may include tender anterior cervical lymphadenopathy and palatal petechiae. As far as complications go, tonsillitis can also result in sinusitis, mastoiditis, otitis media, cervical lymphadenitis, retropharyngeal abscess, peritonsillar abscess, and Lemierre syndrome. The diagnosis of tonsillitis is clinical, although clinicians should consider further workup if suspecting a bacterial etiology of tonsillitis, such as group A strep, Streptococcus pneumoniae, Haemophilus influenzae, Corynebacterium diphtheriae, and more rare cases of syphilis, gonorrhea, and chlamydia. The steps and workup will vary depending on the clinical context and the suspected bacterial pathogen. As with viral pharyngitis, viral tonsillitis is managed with supportive treatment, whereas bacterial tonsillitis is managed with antibiotics against the most likely bacterial pathogen. All right, let's try another question. What is the difference in the clinical presentation of viral tonsillitis and herp angina? Herp angina is an oropharyngeal infection caused by Coxsackie A virus. Similar to tonsillitis, it may also present with a fever, sore throat, and odynophagia. Unlike tonsillitis, it will also lead to vesicles or small ulcerations on the tonsils, soft palate, and uvula. Here is a comparison between viral tonsillitis on the left and herp angina on the right. Note the characteristic vesicles or small white ulcerations in the oropharynx of the patient on the right. All right, now let's move on to peritonsillar abscess. Again, we'll cover the definition, etiology, risk factors, clinical features, diagnosis, and management. Peritonsillar abscess is an acute bacterial infection of the peritonsillar tissues, which is tissue that lies in the peritonsillar space, located between the tonsils and the pharyngeal muscles. It's almost always caused by a persistent bacterial pharyngitis or tonsillitis that, within about a week of symptom onset, can progress to cellulitis and culminate in an abscess. Peritonsillar abscess is most commonly seen in young adults and people with substance use disorder. Clinically, patients with peritonsillar abscess present with nonspecific symptoms, such as fever, sore throat, earache, dysphagia, and odynophagia, all of which can be seen in more mild oropharyngeal infections. Findings that are suggestive of a peritonsillar abscess include muffled, hot potato voice, pooling of saliva, and trismus, which means lockjaw. Classic physical examination findings include unilateral cervical lymphadenopathy, unilateral tonsillar swelling, and deviation of the uvula away from the affected side. Here's an image depicting a right-sided peritonsillar abscess as indicated by the black arrow. Note that the uvula is deviating away from the abscess, which is a classic finding in patients with peritonsillar abscess. Notable complications of peritonsillar abscess include airway obstruction and spread of the infection into the parapharyngeal space. Peritonsillar abscess is a clinical diagnosis. Clinicians may order an ultrasound or CT to localize the abscess, and they may aspirate and culture the abscess fluid to help guide antibiotic therapy. Management of peritonsillar abscess begins with airway management, followed promptly by urgent needle aspiration or incision and drainage of the abscess, and IV antibiotics. It's important to note that IV antibiotics should be started immediately, even before the results of the abscess culture. Empiric therapy should aim at covering group A streptococci, Staph aureus, and respiratory anaerobes, which is usually achieved with either ampicillin sulbactam or clindamycin. The clinicians should subsequently narrow down the antibiotic regimen based on abscess culture. All right, let's do another question. What are the key differences in the clinical presentation of tonsillitis versus peritonsillar abscess? All right, both tonsillitis and peritonsillar abscess may present with fever, sore throat, tonsillar erythema, petechiae, and exudates, as well as tender anterior cervical lymphadenopathy. Peritonsillar abscess, however, may also present with trismus, pooling of saliva, a muffled hot potato voice, and uvular deviation away from the side of the abscess. It's important to remember these differences because peritonsillar abscess is a more serious diagnosis with a more involved management process. All right, now let's move on to discuss retropharyngeal abscess and its main complication, acute necrotizing mediastinitis. As with prior pathologies, we'll cover the definition, etiology, risk factors, clinical presentation, diagnosis, and management. So, beginning with the definition, retropharyngeal abscess is a bacterial infection of the soft tissues in the potential space between the pharynx and the vertebrae in the neck, known as the retropharyngeal space. This space is located in the deep compartment of the neck and is bordered by the buccopharyngeal fascia and the constrictor muscles from the anterior side and the alar fascia from the posterior side. Similar to peritonsillar abscess, retropharyngeal abscess is also typically caused by a persistent bacterial pharyngitis or tonsillitis. The common pathogens include strep pyogenes, Staph aureus, and oral anaerobes, such as actinomyces and bacteroides. Retropharyngeal abscesses are most commonly preceded by an upper respiratory infection, and they typically manifest in children and adolescents, but mostly children between the ages of 6 months and 6 years. This is because children experience upper respiratory infections more frequently, and their retropharyngeal lymph nodes have not regressed yet, making it easier for the infection to spread into the retropharyngeal space via the lymphatic system. Lastly, penetrating trauma to the oropharynx is also a risk factor for the development of retropharyngeal abscess, as it can directly introduce the infection into this potential space. Clinically, there are some similarities in presentation between peritonsillar abscess and retropharyngeal abscess, with fever, odynophagia, dysphagia, drooling, and a muffled voice. Features unique to this include respiratory distress and stridor, as well as severe neck pain, swelling, and nuchal rigidity. There are several notable complications. First is airway obstruction that may happen secondary to significant swelling in the retropharyngeal space. Second is thrombosis of the internal jugular vein, which may happen because the infection from the retropharyngeal space may drain inferiorly into the superior mediastinum and spread to infect the carotid sheath that contains the internal jugular vein. In this way, it's somewhat similar to Lemierre syndrome that was discussed earlier in this lecture. And lastly, perhaps the most important feared complication is acute necrotizing mediastinitis. This may occur if the retropharyngeal infection spreads posteriorly through the alar fascia and into the mediastinum. Patients will typically present with worsening fever, dyspnea, and now chest pain. The treatment for this condition is with urgent surgical drainage to prevent further spread of the infection that could potentially lead to life-threatening pleural or pericardial effusions. The diagnosis can be confirmed with a lateral neck X-ray or a CT scan of the neck with contrast. Here are 2 lateral neck X-rays shown side by side to illustrate the typical X-ray appearance of a retropharyngeal abscess. Take a look at the prevertebral tissue on both X-rays. Normally, prevertebral soft tissue space should be narrower than the vertebral bodies, as can be seen in this patient on the left that does not have an infection in the retropharyngeal space. In a patient with a retropharyngeal abscess, however, there will be inflammation and swelling of the prevertebral tissue, making it appear wider than the vertebral bodies, as can be seen in this patient on the right. Hence, the finding of a widened prevertebral space on a lateral neck X-ray would be consistent with the diagnosis of a retropharyngeal abscess. Similar to peritonsillar abscess, the management of retropharyngeal abscess begins with airway management, especially if the patient is exhibiting signs of respiratory distress, such as stridor or accessory muscle use. Following stabilization, patients should be scheduled for surgical drainage and promptly started on IV antibiotics. Just like with peritonsillar abscess, the usual empiric therapy is with either ampicillin sulbactam or clindamycin. Of course, clinicians should narrow down antibiotics based on abscess culture once it becomes available. All right, let's try another question. A 7-year-old boy is brought to the emergency room in significant respiratory distress. His lateral neck X-ray is shown on the right, next to a normal X-ray on the left. What is the most likely diagnosis? All right, it may be tempting to diagnose this boy with a retropharyngeal abscess since this is the topic of our current discussion. However, if you examine the boy's prevertebral tissue, it appears narrower than the vertebra, which would be inconsistent with the diagnosis of retropharyngeal abscess. Instead, take a look at this area of the neck where one would expect to find the epiglottis. Note the characteristic thumb sign on this X-ray. This sign is suggestive of an enlarged epiglottis, which is consistent with the diagnosis of epiglottitis, an infection typically caused by the Haemophilus influenzae bacteria. For the most part, the main 2 infectious pathologies that examiners expect students to recognize on lateral neck X-rays are retropharyngeal abscess and epiglottitis. Hence, it's important to be able to confidently distinguish these 2 pathologies. Please refer to our lecture titled Infectious Disease from our pediatrics lectures. All right, let's conclude this lecture with a board-style multiple-choice question. A 25-year-old male presents to the clinic with a chief complaint of a sore throat and fever. He says his symptoms started 2 days ago and have gotten progressively worse. He is otherwise healthy and does not have any past medical history. He denies cough. Blood pressure is 114/72 millimeters of mercury, pulse is 82 beats per minute, and temperature is 37.6 degrees Celsius. Physical examination of the head and neck is notable for tonsillar erythema, edema, exudate, and tender anterior cervical lymphadenopathy. Pulmonary, cardiovascular, and abdominal examinations are within normal limits. Which of the following is the next best step in the management of this patient? A. prescribe ampicillin sulbactam. B. Prescribe amoxicillin. C. Order a throat culture. D. Order an anti-DNase B titer. E. Order a lateral neck x-ray. Or F. Order a CT scan of the neck. All right, the correct answer is B. Prescribe amoxicillin. This is a case of a 25-year-old male presenting with a sore throat and fever that have gotten progressively worse over the past few days. His physical examination findings of tonsillar erythema, edema, exudate, and tender anterior cervical lymphadenopathy should prompt suspicion of pharyngitis, especially in the setting of a normal pulmonary cardiovascular and abdominal exam. Recall from this slide that it's helpful to think of symptoms of pharyngitis as either more suggestive of viral pharyngitis or strep pharyngitis. The patient in the question had fever, tonsillar exudates, and painful anterior cervical lymphadenopathy, all suggestive of strep pharyngitis. Now, recall from this slide that in adult patients, clinicians can use the Centaur criteria to help decide the next best step in management based on the patient's presentation. Once again, our patient had a fever by history, tonsillar exudates, no cough, and painful anterior cervical lymphadenopathy, meaning that he scores 4 points on the Centaur criteria. This group of patients should be offered empiric treatment with antibiotics or a rapid strep antigen test. This is why option B, prescribe amoxicillin, is the best answer. Option A, prescribe